Hello everyone, Pulmonology Read Aloud welcomes you to the new May 2023 release of GINA guidelines. GINA guidelines are updated every year, and if you haven't seen it earlier, I recommend that you first see the GINA guidelines 2022 video to have an in-depth review of what entailed in the asthma guidelines. Now, those were a major change guidelines, and this time there's more that is added as an update based on the evidence collected over the past 1 year. So the backbone of the guideline really remains the same as 2022. And today what we're going to do is we're going to understand the key changes that this guideline has brought about. Now, this is a 246-page document on the same format as the previous GINA documents. What is helpful is that they have really tried to answer the questions and the problems that are faced in general practice leading to asthma management, and they've also given future directions. They've talked about something that is going to come new, so we are expecting more documents from the GINA committee. Something that I realize is lacking still is information on newer drugs, newer steroids, inhaled steroids, the ultra long acting bronchodilators. Still not enough information on biologic therapy, not enough guidance on it. The chapter on severe asthma is more or less similar to what it was last time, but definitely a lot of concepts have been cleared, a lot of drug treatments have been clarified. So let's get started. And the first change amongst this 15 key changes is about the inhaler terminology. We all know that two kinds of terminology were initially used, the reliever and the maintenance and controller. And last year only the ball was set rolling where the reliever or Saba use was really discouraged in track 1 being the preferred treatment. So here again they have clarified that you do not use the term controller, you use the term maintenance inhaler, or you use the term ICS containing treatment, or you use the term anti-inflammatory reliever, and maintenance and reliever therapy or MART therapy. So basically what it wants to say is that by saying that reliever, we don't want anybody to confuse with Saba, because Saba is no longer preferred alone. So use the terms ICS containing regimen so that even the patient and the doctor both, they understand the significance of giving inhaled corticosteroids. So basically when you talk about treatment terminology, maintenance treatment, which is to be given regularly on a scheduled basis, can now be called as an anti-inflammatory reliever also. We do not use the terms controller now. We would prefer to use maintenance treatment or ICS containing regimen. Here when we are talking about this, the controllers earlier were ICS containing mostly, and to avoid this confusion, this substitution has been done. When we talk about anti-inflammatory reliever, we again want to say that this will be a medicine, a reliever medicine, which will contain not only a rapid-acting bronchodilator but also a low-dose inhaled corticosteroid. So anti-inflammatory relievers will be preferred over Saba alone. Some patients will require only anti-inflammatory reliever therapy as SOS, so patients in step 1 and 2, and some patients would require maintenance anti-reliever therapy as the maintenance. Now, repeatedly, again and again, something that was very important and something was brought about, a lot of discussions were around it, where in ICS formoterol was prescribed, and we used to synonymously use these terms with other ICS LABA combinations and say that although GINA has repeatedly used ICS formoterol, we kind of could use it in others as well. Now they've specified that the evidence over many years is lacking, so whatever they talk about is mostly ICS formoterol, because most evidence comes from it in clinical trials. And although you could replace ICS formoterol with other combinations, the evidence is not robust in other combinations. And even in MART, most evidence of using maintenance therapy, will be with ICS, budesonide and formoterol combination, or beclomethasone and formoterol combination. So this really brings into question the multitude of inhaler combinations that we have across, and whether all of them can be used for giving maintenance and reliever therapy. So just remember that it's budesonide formoterol and beclomethasone formoterol that mostly have evidence for MART therapy. Now, something which has also been stressed is regarding the explanation of the asthma cycle to the patient, and the importance of looking at this wheel again and again. So assess your patient, adjust his treatment, and review his treatment. And so when we talk about assessment, make sure you have confirmed your diagnosis, make sure the reversibility in spirometry is there, you have controlled, assessed the risk factors, seen the comorbidities, and when you're adjusting it, make sure you're doing all measures to adjust the asthma treatment as well as the morbidity related treatment, and have stepped up or down, and review your patients at intervals, and they have clearly demarcated what should be the timeline. So now if you look at GINA treatment as a third change, they've talked about as needed ICS Saba. So earlier, if you remember, in track 1 we had the preferred controller and reliever and the MART therapy. This is preferred steps where we keep adding the ICS dose and give maintenance ICS formoterol. But track 2, instead of just Saba, there is recent evidence from a trial which says that if you add ICS with Saba, you add budesonide with your Saba, you will have lesser exacerbations. So in resource limited settings, when you are using track 2, you preferably use it with budesonide or with ICS, and that is what is a major change. Now coming to this track 1, again the emphasis has been on emphasizing that track 1 is the preferred treatment in adults and adolescents. So when you're treating your patients, the evidence is in track 1. It reduces emergency visits, it reduces hospitalizations, and it gives us the ability to give a simplified approach to the patient in the form of MART. So track 2 is never your preferred way. Always track 1 will be the preferred management. Now there's been some change also on the guidance on medicines, the doses and the assessment in track 1, and they've realized that there was a lot of confusion in what dose to give, what is low dose, what is medium dose, what is high dose. So they have given beautiful boxes and tables to signify that, and they've again, as I said, emphasized that ICS formoterol is the preferred treatment approach, and the step up and the step down is both important because it will reduce the incidence of severe exacerbations, and this cannot be done with any other ICS LABA because evidence for MART and step up step down is with ICS formoterol, and you can also use it for exercise induced as well as because of allergen exposure. If their patient has an exacerbation, it can be used for both as MART therapy. And most evidence, which is with budesonide and formoterol, comes with the dose of 206 microgram meter dose, which is equivalent to a delivered dose of 160 micrograms of budesonide and 4.5 micrograms of formoterol. So again, it raises a question of giving higher doses of formoterol as in certain combinations that are available to us, whether we should be giving 12 microgram formoterol in the combinations, or we should just stick to the 6 microgram. GINA definitely endorses 206 combination, and then this can be stepped up and stepped down, and 106 for children. And for SOS use, if your patient is taking a 206 combination, then patient has to take another extra inhalation of ICS formoterol. They also specify that for using MART therapy, there is no specific time boundation when the patient should wait. So if we talk about the duration of action of ICS formoterol being 12 hours, there is no need for the patient to wait for 12 hours to take the MART as the reliever therapy. So he can take another extra dose, unlike Saba. And however, when the patient is using 206 combination, the maximum dosages that he can take in a day would be 12 and not more than that. But they hardly require those dosages, and usually maximum some patients can go as high as 8. So this is very important because the dosages is very important to understand. So again, a beautiful table given for doses of MART, and remember that this is via DPI. So here they've talked about dosages which are ideal via DPI, and they have clarified that if you're giving budesonide formoterol via MDI, then you would halve the strength of that with the relevant DPI, and you can double the number of doses given above. So if patient is on step 1-2, he's only on SOS therapy, air only, then budesonide formoterol, he can use it one inhalation whenever needed when he's using with PMDI, right? So dosage with DPI, one inhalation, and whenever he's using with PMDI, you have to tell him to increase, double the number of doses, but try and use an inhaler with half the strength of the relevant DPI. Step 3, MART, again in adolescents as well as elderly. Formoterol budesonide 206 or beclomethasone formoterol 106. One inhalation of DPI once or twice a day, plus one inhalation whenever needed. Step 4, MART, 2 inhalations twice a day and one inhalation for children, and plus one inhalation whenever needed. Step 5, patient on MART, 2 inhalations twice a day. Effective dose becomes 400 of budesonide and 6 formoterol, and one inhalation whenever needed. Also, it's important when you're increasing the dosage to review and response. And when do we review the patient? The answer is 3 to 4 months of therapy, but review for an exacerbation within a week and regular follow-up at 1 to 3 months of therapy. That's very important. And this is the time where you would either step him up or step him down. So day-to-day patient can vary his anti-inflammatory reliever therapy as SOS. Short-term step up he can do according to asthma action plan when he sees deterioration, and a sustained step up for at least up to 3 months to be done when you feel that the patient doesn't have a good response. For step down, a beautiful table has been provided where they mention that you should consider stepping down when you have your patient well controlled, the lung function has been stable, he's been on therapy for 3 or more months, and if he has exacerbations, then you take that into consideration as an evaluation whether you should be stepping down. Choose an appropriate time. All of us do that in our practice. We choose a time where there's not much pollution, there's not much allergen, a time where the patient has less chances of an exacerbation because of a viral infection. We give him clear instructions as to when he can step up, and we give him a written asthma action plan. And when you want to step down, you ideally step down inhaled corticosteroid doses by 25 to 50% after the 3 months. That is safe for most patients. This comes as evidence A or robust evidence. So if your patient is currently on step 5, which is high dose ICS LABA plus oral steroid therapy, when you are stepping down, you would optimize the therapy and reduce the oral steroid first. You can also reduce the inhaled steroid later on. And remember that oral corticosteroids is never the preferable approach on long term in severe asthmatics. So we would try to reduce oral steroids as much as possible, and here this patient can be considered for biologics. Step 4, moderate to high dose ICS. You continue the combination, but you reduce the ICS component, and If you feel that discontinuation of LABA leads to deterioration, then continue that, because it has been noted in trials that if we discontinue LABA, there are more exacerbations. So be careful on that front. Step 3, patients who are on a low dose, again you reduce it from twice to once and see. And for patients who are on low dose maintenance ICS alone, again try to switch them to once daily and switch them to SOS if needed. So step down has to be very careful. Also, whenever you're stepping down, remember there are risk factors, and you want to make sure that this patient who has more risk factors is on an ICS containing regimen and is on anti-inflammatory reliever therapy with a good asthma action plan. And depending on the risks like tobacco smoke, cigarette smoking, obesity, psychological issues, allergies, we can taper the treatment and arrange the other assessments. The next update is about treatment in children, and something which has been added in children. If you see, this is the 2022 flow chart. It talks about step 5, anti-Ig and anti-IL-4 receptor antibody as biologics. But recent RCT have shown that if a patient is on step 5, even in 6 to 11 year age group, they can be given mepolizumab. So anti-IL-5 has been added now, and the new chart shows anti-IL-5 as a part of addition in step 5. So that has shown a reduction in severe exacerbations, and so that is a added option available for children of this age group. Number 7, treatment in 5 years old and younger. So there have been few changes in treatment for patients who are less than 5, so pediatric population. They have really clarified that we still don't have good evidence for continuing maintenance in such children. Most children less than 5 years have wheezing associated respiratory illness. So these patients may require bursts of nebulizations with inhaled corticosteroids or Sabas. So in these children, whether maintenance treatment should be given or not be given is still not clear. There's still insufficient evidence. So if you look at this flow chart, for these children, you have only ICS as either daily dose or double the low dose or continuation as a controller, which is questionable. So this subgroup has insufficient evidence for controllers. Now, number 8, inhaler choice and its environmental considerations. GINA guidelines have really made it more holistic this time. This is a beautiful figure that has been added where they talk about choosing the inhaler not only based on the medication, the patient's own preferences, the training, but also being more environmentally conscious. We know there's a lot of plastic involvement with inhalers, which could fill the landfills. So they want us to choose properly whether we want inhalers that are multi-use, which have a potential for recycling, and we are using now HFA based inhalers instead of CFC, so that is one step closer to being environmentally conscious. But they have stressed upon it with a separate area dedicated to inhaler choice. Coming to the next major change, which is advised for low medium income countries. So track 2, which is the optional regimen, may be the preferred regimen for certain lower and medium income countries, and GINA acknowledges that fact. And the surge of availability of ICS-LABA combinations all across the globe, that's very important, and they have placed a lot of emphasis on making more and more arrangements for that and policies towards that. Number 10, very important change is on mild asthma. Now, even in 2022, mild asthma term was talked about, and they said that mild asthma does not mean that the patient will not have exacerbations, so do not use that term. Now, here again, they have completely asked to replace the term mild asthma because it does not equate to a low risk of asthma exacerbation or asthma death. So a new terminology called apparently mild asthma has been given. We could use this term apparently mild asthma to highlight that some patients may not have symptoms enough, but the risk may still be high. And they've also mentioned that the definition of mild asthma can be different in different scenarios. For trials, for epidemiological studies, we may need to know whether this patient is on Saba alone, whether this patient requires ICS on and off. So those terminologies which are more descriptive should be preferred. Do not use the term mild asthma. Change number 11, severe asthma management update. Most of these flowcharts are same, but they have emphasized that although they have given biologics as an option, make sure it is done only in severe asthma patients where you've optimized treatment. And for more details, you can see my video on severe asthma and biologics and the importance of assessing a patient with severe asthma to make sure he's the right candidate for biologic. Change number 12 on exacerbations. This flowchart, this diagram and table exists in 2022 guidelines as well, but there have been certain changes in medicines and the doses in exacerbation. They emphasize that all patients who are having an exacerbation change their management in accordance with the written asthma plan. They increase their reliever, they increase their controller. Now, reliever here, as we discussed in the first slide, is anti-inflammatory reliever preferably. So the patient who's on low dose ICS formoterol, he will increase the frequency of as needed low dose ICS formoterol as the first step. For a patient who was not on ICS formoterol and is on Saba, he will increase Saba. And for patient who's on combination of ICS and Saba, will increase frequency of ICS Saba. For patients on MART, they increase the dose as one inhalation extra. Patients who are on maintenance ICS and Saba reliever, they can quadruple the ICS dose also. And steroids are to be added for severe exacerbations. And once started, you prefer the morning dose of steroids. They've also given a table on which medication to be used in GINA track 1. And so again and again, they just lay emphasis on budesonide formoterol or beclomethasone and formoterol. They have not given any guidance on other ICS-LABA combinations. And they clearly mention that the data that they have, which have been assessed for MART, has been taken from this combination. So here again, as we did earlier, an inhalation has to be added based on the severity. Number 13, safety issues. They've talked briefly about how pulse oximetry can give us false readings, and we should not over depend on that. We should target a saturation of up to 95% in adults and 98% in children. And for patients with dark skin, be cautious about overestimation of saturation and undermining the severity of the exacerbation. And in safety, they also talk about drug interactions. Specifically, they've spoken about the COVID-19 medication, nirmatrelvir, and they say that there is a significant risk of cardiotoxicity when it's used with ICS salmeterol and ICS vilanterol because of the LABA component. And so, although it's been advised to stop ICS formoterol and ICS vilanterol for patients on nirmatrelvir, you must change it to alternate. You must change the ICS only, or you can change the LABAs and make sure that the asthma is also controlled. Similarly, with ABPA, they have clearly mentioned that because itraconazole also interacts with inhaled steroids and it can cause adrenal suppression and Cushing's syndrome. So when you are prescribing CYP inhibitors, you have to be more cautious and make sure you're titrating the dose. And specifically with two LABAs, salmeterol and vilanterol, when these patients are on such medications with interactions, you can switch to budesonide and formoterol, or you can switch to mometasone as the ICS. Coming to the last two set of changes, the other changes are in terms of referencing simple small things that have to be taken into consideration. This includes one, imaging in asthma. When we talk about imaging in asthma, the guidelines stress that imaging is not needed in everyone, but it is helpful for patients who have multiple comorbidities and you want to evaluate, or patients with difficult to treat asthma for other diagnoses. And also amongst imaging, CT chest and CT sinus plays a important role. Also, they've talked about addition of pertussis as a differential for all ages, and not to forget the variable differentials. They have also recommended that we should not use composite asthma control tools, and we should not use ACQ 6 and 7. We should be using ACQ 5. Now, why not to use composite asthma tools? There are so many risk factors, as you can see, so many conditions that can have asthma diagnosis. So it's very important to ascertain the patient as a whole, talking about his control, his symptoms, his exacerbations. So this beautiful table which is given in the guideline talks about how whenever you assess this patient, instead of using a composite score, you would want to see his control and symptoms. You would want to assess the risk factors for the outcomes. You want to see what are the risk factor for exacerbations, and as a whole, cumulatively want to assess the patient. Also, they've noted that they've given certain advice regarding COVID-19. They've mentioned that it's very important to continue the prescribed medications. They have discouraged us from using FeNO as a guiding tool solely. So they say that we should not be using a single value of FeNO as a guiding tool. And they've also talked about other comorbidities, of which chronic rhinitis is very important. And the guidelines mention that patients with allergic rhinitis usually have, almost 40% may have asthma. So treatment of chronic allergic rhinitis is important. By treating chronic rhinitis based on the guidelines with inhaled corticosteroids, we may have less asthma visits. But for patients who have rhinitis with polyposis, it's been clarified that it may or may not bring about an asthma control, but it will definitely bring about reduction in symptoms. The other comorbidities to be taken care of are fragility fractures by osteoporosis because of steroids. We must look at other pharmacological, non-pharmacological strategies, and vaccination against influenza is highly recommended, though effectively vaccination against pneumococcal has not been shown to have direct impact on asthma, but it is also to be recommended in the right group. The change number 15 is about a future topic. They've stressed that there are many things that need to be updated. We still need to talk about asthma diagnosis in a better way and symptom control. Allergen immunotherapy is something that I really want to watch out for. It may have good implications in future. And COVID-19 and its related changes will happen as and when the disease advances and we know more about its epidemiology. So these are in brief the changes that have been done in the 2023 GINA guidelines. Happy reading, and let's join in again for another session on asthma, and remember to tune in to my series on pulmonary hypertension. Till then, bye bye and stay safe.